Great to see you. All's well?
Fighting my little thing, but it's
Yeah.
better.
Okay.
Yeah. Are we meeting on Thursday?
I don't think so. Not. I think this Thursday and possibly the next. Hopefully next Thursday we might be meeting. And then
Next
after
Thursday I'm starting my group.
great. And then after DBW, I really want to push to make this
Have fun today.
on a regular basis. I think I have a brief conversation at 11:30 that I'm not sure about. So actually, we might be able to.
You mean in a couple of weeks? Or just let me know.
Yeah. So
I'm meeting with you.
Let me see if we can get
might make them early.
where Atra go. Because there should be, Atra should be. We were supposed to have yeah. But she'll know. Let me, otherwise I'll get it.
Schools that are non-circle
okay, good.
that are coming in. So those are
Mine or? That's great. All right, good. That's, I think I put a lot of that a while ago.
yeah, it'd be nice to get more. I should have.
Yeah.
Anyway,
So
it's
we're
gonna
going to
be
be
whatever.
pushing it.
And we haven't recognized any new exhibits so that I'm
No,
that
they
I'm missing.
did.
I didn't know if there was some
There were
type of
3 people that
feature
got randomized into the trial.
I can't offer it to the
No. So at least not. I mean, we have to decide when we're going to call this over, this
Yeah.
phase, because what I'm proposing, which I
Yeah, we can.
yeah, but it's good, and I look forward to November. Oh, great. Did I Oh, I'm sitting over there. Okay. And I'll just put this down.
So, we're gonna have Peg will be I have a 9:30.
You have a 9:30. How are you going to?
Okay. They're filling out their iPads.
Hey, how are you? Good to see you.
Yeah. So what I was saying is that the next step of what I'm trying to do in terms of creating this sort of virtual center is creating a platform for learning. Putting a proposal at this point is too early. I think the right step is to say we need funds for comprehensive centers get together to say this is what we do, what we do. It's great.
And then remind them at the end. I'll just do that, but very quickly.
I mean, I think it may be. I mean, it's but so, and that's the idea of folks in Northwestern opposed to some meeting together for days. So I don't know how this will work. Oh, absolutely.
It's the efficacy. What is the evidence that parachutes work? We should know that.
thing which will be a couple million and trying to manage some private folks also. Congratulations. So today is today's the yeah.
One second.
All right. Good morning, everyone. Welcome to our second Integrative Medicine Grand Rounds. This is very, very exciting, and so glad to see you all here. Before we start today's presentation, I want to just give you a heads up that the next Grand Rounds, which will be on Tuesday, June 2nd, will not be in this auditorium. The Epic rollout is taking over everything, and we were able to scrounge one conference room, it's going to be in the Shapiro Building at 70 Francis Street, so right across the street, in the Pollen Wellness Lounge on the 3rd floor. And after that, this is going to still be from 8 to 9, but we're also going to have a coffee hour immediately following from 9 to 10 in the same place. So I will make another announcement about this at the end, but just beware. So today's presentation, we're very excited. So our format for these grand rounds is that every month a different center or integrated medicine group is going to be leading the discussion. And this month, we're very pleased to have Dr. Darshan Mehta, who's the medical director of the Benson Henry Institute at the Mass General Hospital. Darshan.
Okay. All right. Good morning, everyone. My name is Darshan Mehta. I'm a medical director at the Benson Henry Institute for Mind Body Medicine, and I'm also associate director of education for the Osher Center for Integrative Medicine here at the Brigham. This is really exciting. So we're going to be discussing a case that we all had the pleasure of taking part in of a patient. So let me just dive right in, and then we'll have our expert discussants lead from there. So, just as this is just a disclosure slide, and these have been all been okayed by our CME. So, this is a 27-year-old male who presents with a 6-month history of increased frequency of bowel movements, and previously the patient noted having 10 bowel movements daily. Previously, 3 months ago, he shifted to a diet with low refined carbohydrates and grains. The frequency of bowel movements decreased. He has associated abdominal pain and fatigue, but no melena or hematochezia. I should note that he does report having blood streaks in his stool. Of note, he states that his symptoms fluctuate with his mood, and they are worse during periods of when he reports having increased negative stress. His past medical history is significant. He was diagnosed with Crohn's disease at age 19 and has had a difficult time with the management of Crohn's disease since diagnosis. He's on several medications, which we'll hear a little bit about a little bit later in terms of medical management for his Crohn's, and also vitamin B12 injections. He had no known drug allergies. His social history at the time of presentation was significant. He was a student in helicopter flight school. He's single. He had recently changed his diet to a diet very low, with low starches and refined sugars. His exercise activity, he bikes 2 times a week for 15 minutes, and apart from that, just sort of routine walking. On review of systems, he reports having it's positive for fatigue. His other review of systems on his head, eyes, ear, nose, and throat, pulmonary, cardiovascular, genitourinary, neurological, endocrine are all negative. His GI, as mentioned previously, positive for abdominal pain, for some loose stools. And he does report have anxiety from time to time. On examination, his vital signs are stable, and his physical exam is unremarkable. No tenderness in his abdominal exam, no guarding as well. So I wanted to just show you just from his own words. And I should just tell you that this video was part of a movie that was developed in conjunction, and so this was not just happened to be, but we were able to use this for this presentation.
So my name is Kirk Smith. I'm a helicopter flight instructor. I was first diagnosed as colitis, and then about a year later I got a second opinion, and they diagnosed me with Crohn's disease. It's an autoimmune disease of your intestinal tract and your digestive, stuff like that. When you're young and you get something like Crohn's, it can be just a tough thing. It puts a lot of weight on you that you don't really need. You're trying to make something of yourself as a career and getting established, and then to be held back by just pooping all day long. And it's not the best thing you can be doing when you're 20. My best friend died when we were 17, and that was really hard to take. He was like a reflection of myself, and to have him die, it felt like I kind of lost myself, and I just didn't know how to deal with it. It was definitely a stressor in my life, and I think it was definitely probably a big part in my Crohn's.
Okay. So with that, I'm going to turn it over to Josh Korzenik to talk to us a little bit about Crohn's disease.
Thank you. I'm delighted to be here, both to speak about Crohn's and to be part of this broader presentation, which is very much something is very near and dear to my heart. So Crohn's disease was probably first described not by Crohn's, but by another gentleman in about 100 years ago, and in the British Medical Journal a little over 100 years ago, 1913. And there was a series of patients with ileal inflammation that Crohn's really then championed and brought up as a broader disease category. It was only later that it was understood it was more than just the ileum that was involved. It's an inflammatory disease. It really can affect any part of the GI tract, so even though we think of it as ileal and colonic disease, it's about 20% can affect will have their duodenum affected, perhaps 5% the stomach, and about 2% the esophagus. And so that it can present sometimes in an early age, not with diarrhea or abdominal pain, but even just failure to thrive or poor growth. It affects probably about 800,000 people in the United States, and ulcerative colitis is an equivalent number. It's probably about 33,000 people are newly diagnosed each year with Crohn's, an equivalent of ulcerative colitis. It's more common in the West, so it really was first described in Western Europe and North America, but over the years it's now become really a global phenomenon, so that places like India and China are increasingly describing it, and my guess is in the decades ahead it's going to be much more common in those countries, or at least in terms of numbers. I think the global burden of these diseases will be greater in places like India and China, and for reasons that we don't understand, ulcerative colitis comes into a population about 40 years before Crohn's does. It affects all age groups. It's more common in younger adults. The fastest growing group is actually the age below 6 years old. And why that is, we don't know. Crohn's has sort of a second bump in the slightly over 50 or 60 years old, and we're not sure why that is. abdominal pain, diarrhea, vomiting, weight loss. There are a variety of skin manifestations, erythema nodosum, pyoderma gangrenosum, sweet syndrome. Arthritis is probably the most common extraintestinal manifestation affecting about 40 to 50% of people. Inflammation of the eye in various forms happens in perhaps about 5%. And it's really also a systemic disease. So probably the number one issue is fatigue and just lack of ability to do what they would like, these people would like to do. It's worth noting also that anxiety and depression is much more common, perhaps affecting about 30 to 40% of this population. So what really causes this? This kind of diagram can be appropriate for almost any of the so-called autoimmune diseases, even though we don't have good evidence that it really is a direct autoimmune disease. We know that there's a genetic susceptibility, and there's been over about 143 genes that have been described. But when you have that many genes, it sort of tells you that in part it's not a genetic disease. I think the genetic risk factors are important, but when you look at some of the more common genetic variants that are associated with Crohn's, it may be perhaps as much as 30 to, in some studies, 40%, say, of autophagy will be associated with Crohn's. But when you look at the background population in the United States, about 25% may have that same genetic risk, but don't develop the disease. So it's important, but it's not, and it's particularly important for understanding some of the pathophysiology, but it's not something that we would test for and use at this point in a clinical way. The genetic susceptibility leads to some sort of aberrant immune response, to some slight alteration in the microbiome. We're just beginning to be able to put this together for Crohn's disease. For ulcerative colitis, it's still much more of a loose understanding, and there's some environmental triggers that are probably the critical factor, and what those are we don't fully understand. And those people who are unfortunate to have enough of these risk factors will have inflammatory bowel disease. But really understanding this in a more detailed way is just beginning to emerge in terms of what these risk factors really mean. In Crohn's disease, there is a persistent inflammatory response that leads to stricturing over time. So people get ileal strictures, obstructions from that, and as much as 70% of people will have at least one resection, even with the newer drugs. And then penetrating disease really means fistulas. So whether it's a perianal fistula, whether it's an abdominal abscess, or other types of fistulas that can develop, happens quite commonly as well at some point during the disease. So people really have it's a roller coaster of a disease. There's lifetime or recurrent disease, flare-ups, remissions. It remains sort of medically and surgically incurable. We've had dramatic advances in some of the medications that we use, but it's really still a disease that affects people at an early age and then persists throughout lifetime. And we use this pyramid that we borrowed from rheumatology. We're really in the process of now inverting this so that some of the biologics are used earlier. But for Crohn's, the aminosalicylates are still widely used, even though we're getting away from those because they're not nearly as effective. Steroids carry their own burden of disease with them. And so when we use too much steroids, we've really imposed another set of problems, and we're trying to get away from steroids as much as possible. Immune modulators we'll often turn to, azathioprine, 6-MP, but increasingly we turn to the biologics. So infliximab, adalimumab, certolizumab, and others, particularly targeting anti-TNF strategies, but we're looking at a whole broad range now of other anti-inflammatories that are being used. Some of them can be highly effective. They're also ridiculously expensive, as I think you may all know, so that typically a course of infliximab may be, depending on the dose and frequency, somewhere between $20,000 and $50,000 a year. So patients often can be frustrated. There's the issue of chronic stress. When you ask a patient, why did you flare? Most often someone will say, well, I flared because either this is why I was stressed at this particular time, and this is what happened, or I ate this diet, or I wasn't getting enough sleep. It is really a persistent set of issues that people raise, and I think there's a sense that the healthcare system is really organized at this point more along the medical therapies that are going to be given, and so that the medical encounter is often, what are your symptoms, these are your medications, and the broader concerns that patients have sometimes aren't fully dealt with.
Thank you. So at this point, Mr. Smith, after being evaluated by our team at the Benson Henry, by our physician at the Benson Henry Institute, was then referred to see Peg Baim. And Peg will now talk to us about her evaluation of him and what steps happen moving forward. So Peg.
I turned. I'm not a real good podium speaker, but I think it might work this time. You've met Kirk, which is wonderful to see his sweet face. But he starts the conversation with talking about his trauma history. And at the age of 17, essentially his brother died. His best friend was as if he was a brother to him. And to this day, now that Kirk is in almost 30 years old, he's maintained a very close relationship with his best friend's family. That's very significant for us working in mind-body medicine, because it lets us know that he activated his stress system in a rather robust way when he was very young. And I'll go into a little more detail as to why that's so important to us, and why when we explain the physiology of the stress system to our patients, they get very excited about making certain behavior changes. For us, ground zero for resiliency is going to be their sleep. He said he needed 9 hours, so he really maxed out 9 hours of sleep for him to feel rested. Unfortunately, he really couldn't fall asleep, and once he did, he had a hard time staying asleep. So he had a lot of middle-of-the-night awakenings. His activity, by the time he saw me, he seemed to be a little more active than when he saw one of our physicians. So he was moderately aerobic about 3 to 4 times a week. His diet, which really turned him towards self-care for his own illness management, because when he went towards the paleo diet, his stools actually went from a frequency of 10 a day down to 5 a day. That was a significant turning point for him. And that he also realized that he did have flares when he was under the influence of stress. Socially, his relationships, very important to regulate the stress system. He had lived in Colorado for 5 years, enjoying the skiing over the winter, and loved those expansive views, which is also very significant for us in mind-body medicine, and I'll mention that in a few moments. Had a very rich social life, was having a lot of fun as a young man living out in Colorado. But then he needed to find a career, and his parents moved from Connecticut to New Hampshire, and he moved in with his parents and became a student in helicopter flight school. These 2 images are the 2 images that we present to our patients when we first meet them and talk to them about interventions in mind-body medicine. The very first one that you're looking at here is research out of Yale. This is Amy Arnsten's research, and her lab has spent decades trying to understand what happens to the cerebral cortex under the influence of the stress system. And we explain to patients, and this really explains all of our approaches, that when you're in the stress response, you're actually activating the bottom-up cerebral cortex. And then the interventions that we're recommending are those interventions that are going to grow the neural circuitry of the top-down cerebral cortex. These are 2 competing neural circuitries. Once you're in the bottom-up network, it's a network that stores all memory of threat, real or imagined, and once that network is activated, it then turns on this neurogenic neuroinflammatory response. The bottom-up network then signals NF-kappa B, which I know Dr. Denninger will go into in certainly more detail, but this transcription factor actually then tells the cells to turn on the inflammatory arm of the immune system, that then, in terms of its expression, moves into the brain and starts to disrupt mood regulation, interferes with neurotransmission, and then also grows the bottom-up network. And what you see is that the patient is then victim to this vicious cycle. Our program is an 8-week program. It meets 2 hours a week. Essentially, there are 20 patients in the program, and 4 former patients are invited to come back. There's a charge for the program of $450, but once you've done the program, you can return as often as you wish, free of charge, for relapse prevention. The very first program session goes over the science of mind-body medicine and as it relates to certain attitudes and behaviors. The program in and of itself features about an hour of meditation, learning a variety of different methods and skill development at every session from session 2 to session 8, and also focuses another hour on cognitive reappraisal. Essentially, we talk about the bottom-up network has its own belief system. It's the threat system, and it's really the correlate of all the negative emotions. And the top-down neural circuitry within the cerebral cortex is the storage system of adaptive beliefs, adaptive memories, and positive human qualities. So the cognitive reappraisal is a series of interventions that really augment the belief system of that top-down neural circuitry. When we meet our patients, the number one question for us is to talk about what is their stress history. And the theory is that if your fetal brain is developing under the influence of your mother's stress hormones, then you're born hyper-responsive, which means your brain actually is more vulnerable to activating the bottom-up network. And once that's activated, your cellular response is rather aggressive. This same hyper-responsivity is likely to occur if you're exposed to a chronic period of stress as your brain is developing, usually within the first 18 years of life. And as you see for Kirk, he suffered a trauma when he was 17 years old. His diagnosis of his Crohn's disease was 2 years thereafter. Lifestyle behaviors, ground zero, as I said, is restorative sleep. It appears that when we sleep, if we're not going to bed in that bottom-up network, then we're top-down, and the brain, in a sense, flushes out a lot of these neuroinflammatory molecules, and then we wake up feeling refreshed. The aerobic activity is essential because we don't know any other behavior that grows the top-down neural circuitry more than aerobic behavior, and also increases the cell's antioxidizing mechanisms. Balanced diet is very important because we want our patients to really consume a fair amount of antioxidants and stay away from those food, saturated fat, simple carbs, as you see with some of the changes that Kirk had made. Social support is a mechanism for a lot of top-down growth, a lot of buffering of the stress system, and that not only involves the tangible support, emotional support, but we're also focusing on pro-social behavior and social capital. In terms of the relaxation response, the meditation methods that are part of our program, I think what makes us very unique compared to some other programs that are focused on meditation is that we're building skill in a variety of different methods. These are the methods that are built into our clinical program. And then these are the strategies. We have a series of strategies that are involved in cognitive reappraisal to build the expression of positive emotions, to decrease judgmental awareness, which is often an unnecessary activation of the stress system, by enhancing functional expression of empathy. We also have some writing exercises, journaling. We have our patients pick a bunch of words out of a container and to use those words to create a poem, so they can actually begin to connect to creative expression. If they're bottom up when they create a poem, they're going to project their suffering. If they're top down when they're creating their poem, they're going to actually begin to express very naturally their healing process. Humor is also very critical. It's a top-down function. Studies have shown that individuals that are the most emotionally developed among us have also a very well-developed sense of humor. And everyone, to build in social support in our program, picks a number out of a hat, and if you've got the same number as someone else, that's your partner, and we ask them to just touch base with each other once a week through email or a phone call to give each other support for the homework. The symptoms that Kirk presented with, essentially we ask our patients to give us the top 3 most bothersome symptoms, In terms of tracking, we ask them to track their symptoms on a weekly basis for frequency and intensity. You see his frequency of stools that he talked about in his video presentation. He essentially felt that the urge to stool was nearly constant for him, gave it a greater 10 times a day for his frequency. The intensity was very burdensome, 9 out of 10, and he was observing frank blood twice a week in his stools. He had abdominal pain several times a day, 5 out of 10 intensity, and correlating with that neurogenic neuroinflammatory response of interleukin 1 and 6, he was experiencing fatigue several times during the day with a 4 out of 10 intensity. The next two slides are showing you the initial goals that are set with all our patients, and it gives a good capsule summary of all of our approaches. When patients go through the program every week, they're asked to tell us their frequency and intensity of their presenting symptoms. We introduce the relaxation response as a top-down physiology, and we also, at our first meeting with the patient, we give them a variety of apps that will allow them to have a guided meditation experience, and we also teach them to meditate on their own. We give them the recommendation for some good top-down neuroplasticity of meditating for 10 to 20 minutes once or twice a day. 20 minutes is likely giving you more of that neuroplasticity support top-down than 10 minutes. Minis are essentially diaphragmatic breaths that activate a parasympathetic response and buffer some of that sympathetic stress response. We're asking our patients to do diaphragmatic breathing several times an hour. And exercise is the number one behavior that we're really focusing on to give them a lot of that top-down support for neurogenesis and the antioxidizing mechanisms. The recommendation is essentially a half an hour a day, 5 times a week, 30 minutes. The diet is a diet out of the Harvard School of Public Health, essentially a lot of fruits, vegetables, whole grains, obviously something that Kirk wasn't able to tolerate, good sources of lean protein, not a lot of refined sugars. Cognitively, we're trying to get our patients to move into the belief system of the top-down neural circuitry. We tell them to really capitalize on the placebo response. So when their mind moves into the future, to really focus on that which is in their best interest. So we're focusing on positive expectation, really expect good things, and to practice the thoughts that reflect that until they actually do feel that positive expectation. The other belief that's generalizable and the most studied positive emotion that's easily accessible is appreciation. Anything in your life that's of value, to focus on that, especially a few hours before you go to bed. And anything that's challenging, you can always compare down, realizing that it's not as bad as it could be. That'll also lead you into appreciation. We go over supports to make sure there's emotional and tangible. We talk about pro-social behavior, and we'll set goals with that if the patient has needs. And then in terms of sleep, again, that is probably the most significant behavior change that we would want to see. Short sleep duration, which was Kirk's problem, is caused by an engaged stress system. So it takes about 2 to 3 hours before you go to bed to be able to think in a way that you put your brain to bed in that top-down neural circuitry. Your brain is going to operate under the network in which you put it to bed in. So positive thoughts, to the best of his ability, a few hours before he goes to sleep. We talk about light therapy during the day, dark therapy at night to support the normal circadian rhythm of sleep, and just some other regulation to decrease light exposure with a lot of devices that we use in watching television. And then I'll close on this slide just to let you know these are the meditation practices that we introduce. Essentially, this is our meditation starter kit for our patients. We've learned that if you do a variety of methods at one sitting, you're likely to have a better physiologic response than doing one particular method for 20 minutes. Begin with breath focus. Then we'll have them focus on an adaptive word, phrase, and or image in rhythm with their breath. They could translate the focus of a word, phrase, or image from a positive experience that they've had, which we know will be stored top down. What's also important is we ask them to spend about 5 minutes of their 20-minute daily meditation practice seeing themselves in that idealized expression. We tell them essentially that their brain, to some degree, is a servant of their mind, and if they can give their brain about 5 minutes exposure to seeing themselves as they desire themselves to be, that their brain will likely support them to move in that direction. We explain chanting as a top-down version of rumination, which a lot of us have had experiences of, and we talk to them about prayer as a means also eliciting the relaxation response. And the last method here is from Thich Nhat Hanh, very concrete, very user-friendly, to simply memorize 12 words that are top-down or neutral words for you, and to focus on those words in your mind's ear, also in rhythm with your breath. Great.
Thank you, Peg. So one of the things we've learned from the clinician experience is how this translates into research. And so I'm going to now invite John Denninger, our Director of Research, to really talk about the actually literally hot off the press stuff as it relates to.
I was going to say the timing for this could not be better, because we literally had our study, which I put as in press when I put these slides together last week, went online this past Friday, and the press release is today. So this is a pilot study that was done in a group of both IBS patients and IBD patients. One of the novel things about it is we put these folks together in one of our SMART 3RP, our stress management groups. I'm going to just be talking about the IBD patients today. These were 29 patients. And what we're looking at here first will be some clinical findings, some self-report findings, and then I'll look at some of the genomics. So what we've got is, for this slide, is decreased pain catastrophizing the IBD patients. And what you're seeing on the x-axis there is the pre, mid, and post group time points, followed by a 3-week later time point. And what you can see is a significant decrease in pain catastrophizing, which is essentially patients' emotional reactions to their pain, how they relate to their own pain. In addition, we saw on the state trait anxiety inventory, we saw significant decreases in the IBD patients in trait anxiety, both at the immediate post-group time point and 3 weeks later. We also saw improvements in the IBDQ, which is a measure that captures quality of life and IBD symptoms for IBD patients. And again, significant improvement in that, both immediately after the SMART 3RP group, so immediately after our stress management resiliency training group, and then 3 weeks later. So that's pretty exciting, but even more exciting are changes, and I have to admit that this is in a group of 29 patients. These are relatively preliminary. This was not a controlled study. This is just a pre-post examination before the group and after the group of how genetic expression changed in our patients with inflammatory bowel disease. And I should hasten to point out that Josh was mentioning earlier, was talking about genes. These are not, we're not talking about allelic differences between patients with IBD and other folks. We are talking about how genes are turned on and off, so how genetic expression, how mRNA levels change in peripheral white cells in these 29 patients alone. Does that make sense to everybody? So what we're looking at here is a heat map. Are people familiar with heat maps, at least somewhat? Maybe not, so I'll describe it quickly. So what we have is in the columns, and is my pointer showing? Yeah. In the columns we have individual patients. So on the left half, these are all of the patients in the group, all of the IBD patients prior to the group, and then all of the IBD patients after the group. In the rows are individual genes, and you can see them named here. I cannot tell you what all of these are, but I will tell you about a few of them. And then you can see in the top half here we have genes that go from, red is relatively upregulated, green is relatively downregulated, so more or less of a given messenger RNA for a given gene. These genes in the top half go from relatively upregulated to relatively down, from before to after the group. And these genes in the bottom half go from relatively downregulated to relatively upregulated. And I'm just going to focus on a few of these genes here that are in the downregulated portion. A couple, cortactin and GTPase RAB11A, which are important in interferon regulation and signaling, and do things like are required for things like endothelial barrier functions and extravasation during inflammation. GTPase RAB11A is involved in events in the innate immune response. So two genes that, and again, we're just getting hints of mechanism here. These are genes that may be involved in some important way in the mechanism of mind-body therapies in inflammatory bowel disease. And then finally, these two genes, EDIM1 and EDIM3, were downregulated in our program and are typically upregulated in IBD. So interesting suggestions. Peg mentioned NF-kappa B, which is a central immune regulating molecule. It's a transcription factor. This is a network analysis, and I don't have time to go into great depth here, but just to say that what we were trying to find with this is what molecules are the key hub molecules. The key hub molecules, and I sometimes show a slide with one of those, airline flight path things where you have the hub cities and all the lines are coming out of them. It's a similar idea in that in this we see NF-kappa B, which is this central immune regulating molecule, as a hub molecule. So that means that that's a molecule that's talking to a lot of other molecules. And it's very gratifying for us to see that in this patient population, we see NF-kappa B as an important molecule in the same way that we saw and other groups have seen NF-kappa B being important in healthy people when they meditate or go through a stress management program. And then finally, just a couple of methods that we use to, there's a lot of data that gets generated here, literally, hundreds of thousands of pieces of data. And so one thing that you have to do with this kind of stuff is use bioinformatics to separate the wheat from the chaff. And what we're looking at here are gene set enrichment analysis. So gene set enrichment analysis basically asks the question, which sets of genes that are separated into biologically meaningful categories, which sets of genes are overrepresented in the ones that we see change? Among the ones that were overrepresented are things related to the cell cycle, to apoptosis or cell death, to the immune system, and to the extracellular matrix. And then if you do something that's called leading edge analysis basically says in all of those gene sets where you had gene sets and biologically important gene sets that were overrepresented, which are the specific genes that show up the most? And the leading edge analysis, this is the number of gene sets that each of these genes shows up in. And what you can see is that some certain proteins like cell cycle and apoptosis related molecules, a number of the MAP kinases, for example, are one of the kinds of genes that show up quite a bit in the leading edge analysis. That means that those genes are likely mechanistically important. And then you can see that most of those genes, as shown here in another heat map, are downregulated in the patients before versus after the group. What does this mean? Well, what this means is that we are starting to get some important implications, some important ideas about what may be mechanistically important in how mind-body therapies can be effective and important in inflammatory bowel disease. Thank you.
So these types of findings have been really important in understanding how our clinical interventions have evolved in the management of inflammatory bowel disease and in particular in Crohn's disease. And so I wanted to invite Josh to maybe discuss a little bit, how this type of research has informed your sort of new clinical interventions.
Very much so. So thank you. So the timing really is perfect. It was a great, very interesting and very enjoyable to work on that project. And that project and a more direct involvement with the program really crystallized some of my thoughts and expectations for how we wanted to develop our IBD center. And I was fortunate to actually shift from Mass General over to the Brigham and have the opportunity to build an IBD center. And so we wanted to have this sort of program very much embedded in our center when we started. And so we have something called the CIRCLE program, which is a comprehensive IBD resource for care, quality of life, and education. And I should actually really, to be in full disclosure, say in part that some of the motivation that I had for this was very much the program. But that when I was growing up on my father's bedside table was actually Herb Benson's book. And so I read it more than 40 years ago and was fascinated by it and wasn't quite sure how to bring this into practice. And so over the years as a medical student and onward, I was trying to figure out how to bring this in. And something else which I don't talk about that much, but that I got married. My wife, perhaps not by coincidence, has ulcerative colitis and had worked for the Crohn's and Colitis Foundation. And then our son, at age 3, was diagnosed with ulcerative colitis. And my sense at that point was that there's something profoundly inadequate about our care and how we provide care in inflammatory bowel disease, and wanted to do something different that was going to broaden it and really provide a type of care that I would want for my family. And so that's part of the motivation for the Circle program. And then it was very much informed by the work with the Benson Henry Group and with Leslie, and really how can we then make this something that would be accessible for a broader population. And so the organizing principles was that care is customized and reflects an individual's needs, values, and choices. Care is based on a continuous healing relationship, and all team members are considered caregivers. We wanted to do this in the setting of a controlled trial initially to really show that we can not just, we wanted to provide data, both in terms of genetic type of information, in terms of biologic types of data, but also we wanted to show that we can really improve outcomes and reduce healthcare utilization. We wanted to address the psychosocial needs, we wanted to change behavior, and most importantly, we wanted to alter the nature of the relationship between patients and their providers, to shift that type of involvement and hopefully then bring about better outcomes. And I'm just going to describe it very, very briefly here. It's really a personalized program to address the broader needs of IBD patients. It's targeting initially in this first iteration high-end users, which we have a definition of 2 or more hospitalizations in the past year, 3 or more ER visits, 5 or more clinic visits. And as with any chronic disease, it's a very small population that tends to be the high-end users. So when we looked at our hospitalizations over the last 2 years, at the Brigham, we had about 1,000 hospitalizations, and about 13% accounted for about 46% of hospitalizations as unplanned hospitalizations. So when we looked at that population, it was particularly the risk factors really were anxiety, depression, other psychosocial needs and problems, and chronic pain. And so we wanted to target a program to meet those needs and see if we can reduce healthcare utilization. So we have a program where all patients are initially screened by our social worker, Lori Ashworth, and develops a program with the patients. And that program involves a variety of parts. There is a nurse educator. And initially, we looked at this as an education program, but we felt that when we look at the education alone in IBD, the 13 or so studies that have been done, only 1 or 2 showed a benefit, most show no benefit, and 1 showed a deleterious effect. So we really felt that we needed to put that into the context of a broader program. Nutrition is critical, and Caitlin Hosmer-Kirby has been fantastic and is part of the OSHA program here as well. Leslie Kagan, who'll be talking a little bit, has been just fantastic in terms of both leading the programs as well as in our frequent meetings, teaching us more in terms of how best to take care of these patients. We have a psychiatrist who's also part of our team, and we're also trying to utilize technology to expand the program. So we have an app that we've developed. We have a special website, and we have video visits as well to try to, because there's a certain burden on the patients of very frequent visits in the first 6 months, we've tried to minimize the time that would take, and we're trying to expand that further. And the aim is really to enhance patient involvement in their care, to shift the provider-patient relationship, to develop an alternative model of care, and hopefully the goals will be then looking at a randomized clinical trial, which is ongoing, and we're, I think, at about 75 patients so far, to see if this program will reduce the disease activity and improve outcomes and reduce healthcare utilization. And we're really trying to take that other model that I had showed you before of the sort of biologic model and shift it so that it's really certain elements of care are critical. There's a medical care part of it, But that's only one part of it. There's education, there are disease management tools that we want to provide for patients, and psychosocial care. And then around each of those, there's issues of nutrition. There's a broader care group of physicians, physician's assistants, nurse practitioners, educational programs, and then there's the technology issues of whether it's patient gateway, access to information, websites, mobile apps, but then there's the psychosocial elements of whether it's psychiatry, stress management, and a health coach to help people get there. And so we've really been very fortunate. We had a very nice grant from AbbVie, who really has no direct involvement in this, so we were pleased that they were so motivated to do this, and really has helped us create this program that now is really informing the rest of the center. So even though it is a specific program for a number of patients who are enrolled, these services are now being rolled out to the broader population. Patients are, they really describe this as life-changing, and both in terms of a care model, in terms of a sort of attraction for patients, in terms of a national reputation for the Brigham as well has been very helpful, so that the American Gastro Association is eager to feature this. There's a program coming up where people are coming around, junior investigators from around the country are coming in to understand what this is, and we're working on our next phase. So we're very excited about this. I think the crystal of this really came from the Benson Henry group, and I've been delighted to be able to bring this to a broader population and see how this can be a model for other chronic diseases. So thank you.
So one of the interesting things about this whole journey has been the integration of research, clinical application, and then reflecting on patient experience. And I wanted to ask Leslie just spend a moment to just talk about her journey in that process, if you can. Yeah, I think it'll be easier if you just come up. Yeah.
Hello, I'm Leslie Kagan, so I'm a nurse practitioner. I work with PEG over at the Benson Henry Institute, and I've been running the Mind-Body program for the Circle program. And I'm just going to make a couple of points. In terms of modeling the program for the research project, we decided it wasn't a 7-week program, it was a 6-week, 2-hour program. The goals of the program were the same as Peg mentioned in the Benson Henry in her slides, really to empower patients and provide them a lot of awareness building in terms of stress triggers for their symptoms, but also in terms of providing them a set of skills to help buffer the effects of an activated stress response. In terms of providing the program, we had to be really flexible because this was a very ill population, and either they signed up for the group and then they were hospitalized or they had a flare. So we were very, very flexible, and we allowed patients to come in for the group, to retake the group, to work individually with me, to work with me by phone. So we were incredibly flexible in terms of allowing them and providing different ways for them to learn these skills. Once the program was over, I stayed in touch with them. We've had reunions, we've had individual skills visits. Some patients take me up more than others, and that's the whole point of the Circle program, is really how do we individualize care so that patients feel empowered and they take charge of their care and their health. It was fantastic working with a team of providers. We had the luxury of meeting every week and hearing patients being presented from the different perspectives, whether it was social work or education, or Caitlin, who was fantastic in terms of dietary stuff, and Ash, our psych provider, as well as Josh and all the others on the team. So that was really, really valuable, and I think it also enhanced patient care because we really got to know the patients. I got to know some of these patients before I even met them, so they really felt very taken care of. And I'm just going to, I have a few notes from Caitlin. One of the things we've noticed in terms of nutrition, and I think that maybe you can talk about this a little bit more, is that there really are no randomized controlled trials in terms of recommendations for diet. Peg talked a little bit about the goals, and really there are approaches, and some providers are reluctant to even address this. So there are approaches and guidelines that can be used to maximize nourishment and enhance the body's innate ability to heal. So it's one of the things that we're looking into in terms of the Circle program, and has been a wonderful addition for the patients in the program. They've been able to meet with Caitlin individually and feel so much more empowered and knowledgeable about their nutrition and their diets. And I'm just going to leave you with a couple of quotes. So these are from two patients who went through the group. One of them said, "I learned so much with people who could relate to my issues. I will use what I learned every day, do the work, and it will change you." And here, the second is from my very reluctant patient who the first time through fell asleep every time we tried to meditate. He was so frustrated with himself, and I did convince him to come back and do it a second time. But this is what he said: "Incorporating a meditation into my everyday life has provided great benefits. I have learned that meditation can be done in many forms in just about any place or situation. Studying a picture in the doctor's waiting room, taking a deep breath while sitting in heavy traffic, or just enjoying the sounds of the birds in the early morning are all ways I have learned to cope with IBD illness and life in general. These new skills have helped me experience better sleep, less stress, to generally remain calmer and accept life's challenges in a better fashion." So.
Thank you, Leslie. So I'm going to invite John, Peg, and Josh to come sit up front. We're going to move to questions. And as we're doing that, I just wanted to just say this patient, Mr. Smith, post, we'll see that his symptoms really improved on all three fronts in terms of loose stools, abdominal pain, and fatigue. And we can see that even in just an 8-week intervention, we were able to have at least subjective improvement. Peg, I'm going to invite you to come up front as well. So, all right, we wanted to, this is really meant to spark discussion and dialogue, because this is a case study and how the research has informed clinical practice, and then how clinical practice reinforms research and new clinical innovation. So wanted to see if there are any questions from the audience for our panelists here. Yeah, Gary. And we're gonna hand the mic over. We're gonna have, so if you can raise your hand in advance if you have a question, then it'll be helpful to our mic runners. Oops.
So this is fascinating, and I'm the director of the Pain Research Center here, so I'm interested in this sort of approach. This may be a premature question, but what sort of recidivism is there? Do people continue with this relaxation response practice after their symptoms abate, or they're less? Do you have any sense how long-lasting this is?
So I can't give you our data in IBD yet, because it's an ongoing program. I think that, I'm sure, as in life, what happens with people are feeling better and then they sort of drop off, but I'm sure you may have better data in terms of some of your other programs in terms of how long people stick with the program. I think many people do see it as something they then incorporate into their daily life in long term. And I think that the program that Leslie has in terms of a reinforcement and sort of alumni come back and do this has been very valuable at reinforcing that and seeing people doing this not just when they're ill, but when they're well as well.
We actually have 5-year follow-up. I carry my own mic with me. We have 5-year follow-up with our patient population, and one of the things we've learned is that they need ongoing support, especially for continuation of a meditation practice. When we show them, they come to us because they're actually suffering, and then within a very short period of time, they can regulate some of their own stress response, and they feel so much better that we become a safe place for them, where and they want to, we're a touchstone for their healing. So they want to maintain relationship with us. They've asked us to make apps, do virtual programs for them. But we give them a lot of support for other venues for building a meditation practice in our area. And so we give them that ongoing social support to cultivate that meditation practice. But I will say one of the most important features is that they can come back and do our program as often as they want, completely free of charge. And that means 4 former patients can do the program again, and they're embedded with new patients. And that in and of itself is freedom, to know I can always come back. I don't have to be able to master these skills in just a very short period of time. And then the new patients have the support of former patients that then become leaders in a sense, or teachers that reinforces their own practice. So that's a very strong relapse prevention strategy.
So we have an R01, not in an IBD population, but in a chronically stressed population that's going to be wrapping up within the next 6 months. And we don't have the data yet, but we'll be able to track whether people continue practicing over the course of 4 months after being in the program. I think sort of clinical experience says that some people really get it and stick with it, and other people don't. But I don't know the numbers.
Yeah. Question. Yeah.
Really interesting talk. Enjoyed all the different facets of it. I was curious with the very exciting data about the gene regulation and some of those pathways. Besides really solidifying and hopefully getting some good credibility, which is deserved for this, do you have a sense of how you're going to maybe feed that back into guide then the counseling of the patients? Is there a pathway for that to say, here's gene regulation, we can alter, ways we encourage meditation or what we target in our, patient counseling?
I mean, I think at some level it's definitely very satisfying, both for patients and for the people who treat them, to be able to say that this is not just something that our experience says is helpful, but that there is a biological mechanism that we can point to. I mean, again, as I always say, these are early days in figuring this out. I mean, it may get to the point where in the future, a given subtype of inflammatory bowel disease, Crohn's, for example, we may be able to say that a certain kind of meditation or a certain kind of practice may be most helpful. I don't know, Josh, if you had thoughts.
No, absolutely. I think it helps unify it and solidify it, giving it a good grounding. But as John's saying, it's just, this is early on, and these are small numbers of patients, and so we're eager to take this further and see this as really just the beginning of a foundation.
Other questions? Yeah, Randy.
It really is a fascinating, wonderful confluence of programs and results and genetic evidence. I don't know this research very well. I just heard of it the last couple of weeks. There's a person, I think, whose name is Michael Meany, who's doing research on epigenetic effects from early mothering. He sort of has this equivalent. There was research on voles and looking at high licking versus low licking maternal voles and oxytocin and some of the things. And I'm just wondering if there would appear to be some research even in a 25-year-old, a person with trauma at 17, that would show some epigenetic kind of turning on of top-down calming capacities. So that's one question. The other is just about a person like this recovering from trauma. Bessel van der Kolk's recent book, The Body Keeps the Score, sort of speaks to a lot of the relevance of this research. The notion that you have to start with the body and meditation and calming. But my experience from a psychoanalytic, psychodynamic point of view is that sooner or later, for the sustaining of a change, people do need to arrive at or get help developing a narrative that accounts for what happened to them somehow. It accounts for the meaning of the loss of his best friend. And so I'm wondering if there's any plan for that kind of longitudinal narrative development in this program.
So, John, you may want to answer the first part, and then Peg.
On the epigenetic front, I mean, one of the interesting things about epigenetics, which really includes all of the ways that DNA expression can be regulated, is that there are some epigenetic changes, DNA methylation, for example, and histone modifications, that may actually cross generations. So it may be possible, this is stuff that is still being understood, but it may be possible for some experiences of a given organism to be transmitted to offspring. So that's important. Obviously, we are just starting to get into looking at some DNA methylation changes that explain what's upstream of the kinds of things that I showed here. So there's definitely a lot that I think we will be able to say, but we can't say it yet.
Peg, you want to address a second
Oh,
question?
sure. Well, I think, there's a little prenatal research that shows that when mothers are meditating, that their babies have longer telomeres. We're familiar with Michael Meany's work. There's a body of research that talks about these epigenetic changes and makes these patients hyper-responders, more vulnerable to their genetic vulnerabilities. And I think that explaining that to patients, and this is a very strong theory right now, allows them to feel that they can regulate part of their stress system, and that's actually going to have a significant impact on their ability to regulate their illness.
So I want to just finish up with just the concluding part of Kirk's statement, and just to hear it from his own words. And then our speakers will be around for a little bit if you have other further questions. We'll wrap it up here.
Things started to change for me when I found the relaxation response resiliency program. And just when I could calm myself down, get through the day, my Crohn's just started getting better. And I feel better. The mind-body connection, I really believe in it. You can feel it when you believe in it, you just know it. And you can see the difference in yourself in day-to-day life. Just the way you go about things, you're a happier person. And things become easier. Right now I'm doing really well, so that's pretty good.
So this is part of a larger documentary on mind-body connections. But again, wanted to just mindful everyone's time, and wanted to thank everyone for coming to this presentation. We hope you enjoyed it, and we look forward to seeing the date for the next one. Helen, and we'll recap here.
Well, thank you so much, Dr. Mehta, Dr. Korzenik, Dr. Denninger, and Peg. I mean, this is just... I think this really exemplifies what we were aiming for in these series. We are looking to show people connections, bridges, building bridges between disciplines and also between institutions, which I think is quite remarkable here in this example. So another bridge, the next one we're going to look at is, it's on June 2nd, so this is going to be a presentation of a patient with carpal tunnel syndrome, and the discussion is going to be led by Dr. Vitaly Napidov from Mass General Hospital, but it's also another discussant is going to be from the New England School of Acupuncture, and also from the Brigham. So it's going to be another one of these very cross-disciplinary and cross-institutional presentations. So I'm welcoming you again. Please note the location as an exception. Is going to be in the Poland Wellness Lounge on the 3rd floor of the Shapiro building, right across the street. This is only for the June presentation, June 2nd. After that, in July, beginning in July, we're coming back here, and it's going to be the first Tuesday of every month from 8 to 9, followed by a coffee hour. So look forward to seeing you again next time.
And one last thing I forgot to mention is that the PLOS One paper, which just came up, PLOS One, one of the great things about it is an open access journal. You can get it right now, that paper, on your iPhone if you want. Whatever device you have, just Google Hagen, Korzenik, Denninger, and PLOS One, and it'll pop right up. And I also wanted to say that regardless of how many times I am told, on June 2nd, I will no doubt come here first.
Fantastic. Thank you so much. That was fantastic. That was awesome. Great.
That was perfect.
Yeah.
That was just right.
Yeah.
I mean, I think this is exactly what we were hoping.
Yeah. I did
A wonderful job.
Good. Yeah. You got even a few questions in. And big crowd. This was great. I don't even know if half of the. I
think it was almost twice as much as last time.
And a lot of new people, and even our own people did. We had a couple of our people, but more. I thought I wasn't expecting more of our own that didn't come.
This is taking hold.
Yeah.